everyone. Sorry that this didn't get recorded last night. My voice was kind of giving out on me, so I wanted to make sure that guys could understand it. So this is care of the patient with lung cancer, and it's in chapter 30, and it's on pages 586 to 593. Student learning outcomes. Describe the etiology and development of lung cancer. Teach the patient and family measures to prevent lung cancer. Describe diagnostic measures and treatment. Formulate a plan of care for a patient undergoing surgery for lung cancer, and prioritize care of a patient with chest tubes. Lung cancer facts. Their poor long-term survival due to late-stage diagnosis. It is the #1 killer in both men and women in the United States. A little reminder with patho, lung cancer pathophysiology. Primary lung cancers are a result of failure of cellular regulation in the bronchial epithelium. Bronchogenic carcinomas can be both small or non-small cell lung cancers. When lung cancer metastasizes, it's a direct excision through the blood, invading the lymphatic glands and vessels, metastasizing to the bone, liver, brain, and adrenal glands. Paraneoplastic syndromes are syndromes caused by the hormones secreted by the tumors. And this isn't just for lung cancer, it's for all cancers. Staging to assess the size and extent of the disease is the T is your primary tumor site, the N is regional lymph node involvement, and M is the distance to which it has metastasized. Lung cancer. When we're taking a patient history, it's important to ask about risk factors. And it's one of those things, if you look at this, ask about the symptoms on table 30, in chapter 30, table 5, it looks at the shortness of breath, the coughing, the dyspnea. And when people come in with that being their chief complaint, it makes you make sure that you ask these questions concerning your history. There are some genetic and environmental causes, including second and third hand smoke. There are work exposures, such as asbestos or coal dust from the coal mines, mustard gas. The military was exposed to that in both Korea and Vietnam. And now these older gentlemen are having lung cancer secondary to this exposure. Air pollutants such as hydrocarbons. But the main reason that people have lung cancer is from smoking. 85% of deaths from lung cancer are from smokers. So it's very important when someone tells you that they smoke that you calculate their packs per year. And that is the number of packs per day multiplied by the number of years the patient has smoked. Lung cancer signs and symptoms. Primary prevention for lung cancer is directly related to reducing tobacco smoking. Secondary prevention is early detection by CT scan, which can diagnose stage 1, in which the survival rate is greater than 5 years, because late stage lung cancer has a survival rate of less than 5 years. Specific symptoms are related to the location of the tumor. Again, let's see table 35. That would be 30-5. They can have coughing. They can have wheezing. A lot of times they'll develop a fever and weight loss. But these are once the tumor is already presenting with symptoms, the patient's lung cancer has usually already metastasized. Lung cancer treatment, non-surgical, could be chemotherapy and radiation. Radiation many times is the focus of palliative care. Sometimes they can shrink the tumor in order to have the patient be able to breathe easier or to decrease pressure in the chest. A lot of times, the patient will have both chemotherapy and radiation. Um, and they will sometimes have a round of a round of treatment of radiation, which is usually about 6 weeks prior to having surgery for their lung cancer to try to decrease the size of the tumor. With surgical management, there are 3 types of lung cancer surgeries and 2 different methods that the surgeon can perform them. Surgical management can be a lobectomy, which is the removal of an entire lung lobe. A pneumonectomy, which is the removal of an entire lung. A wedge resection is the removal of the peripheral portion of a small localized area with disease. Now, the lobectomy and pneumonectomy can both be performed by open thoracotomy. The lobectomy and the wedge resection can also be performed by the video-assisted thoracoscopy surgery with the use of a robot. This is less invasive and the healing time is decreased. Let's look at what the nurse's responsibilities are preoperatively for a patient who has lung cancer and is going to have surgery. We need to make sure that we can answer any questions that the patient may have concerning the operation. And if they have doubts or have extensive questions, that prior to being medicated for surgery and signing their consents, you consult the surgeon again to come and speak to the patient concerning their concerns. Does that make sense? So, like, even though I've all about it and I plan to get the surgery done, if the day of surgery you're my pre-op nurse and I've come in and I'm like, I'm really concerned about this, that, and the other. If it's very simple, like, can you tell me again about the recovery time? That's something the nurse can answer. But if it's like, well, do you think this is going to cure my lung cancer? These kinds of questions, you would need to contact the surgeon so that they could have another conversation with them prior to the surgery. Another important job of the preoperative nurse is to inform the patient of what to expect postoperatively. It's important to go ahead and teach the patient pre-op about using this incentive spirometry, about shoulder exercises that will help to regain range of motion in the arm that is on the affected side. Also to talk about the location of the incision and care of the incision postoperatively. And I think it's important to tell people what a chest tube looks like and that they will have them postoperatively if that is the plan. Common incision locations for both partial and total pneumonectomies. It really depends on the location of the tumor. Some are mediastinal. I rarely have seen them there because they have to remove the sternum. I've usually seen the posterolateral incision or an anterolateral incision, depending on where the cancer location is. I really can't recall if I've ever seen a medial sternal incision done for lung cancer. Now, I'm sure that one of you guys will say, my mother's uncle's cat had it done that way. That's cool. I'm just saying I've never seen it. I've always seen the postlateral or the anterolateral method. Surgical management of postoperative care. And this is for the pneumonectomy. And remember that a pneumonectomy is the removal of the entire lung. A closed chest tube is not usually used. Sometimes they'll place one that is clamped for a day, but a regular chest tube system is not placed in a patient with a pneumonectomy. Serous fluid collection in the empty space creates adhesions that actually help to reduce mediastinal shifting towards the affected side. Because if you think about it, you now have an entire side of your thoracic cavity that has nothing in it. And so these adhesions actually help to prevent mediastinal shifts of the heart and the other lung into the opposite side. Positioning is very much a surgeon's preference. I have worked with surgeons who say they have to lay on the affected side. I've had surgeons that say they have to lay on the unaffected side, that they have to stay on their back. Just know that positioning for a pneumonectomy is a surgeon's preference. Complications for a pneumonectomy include empyema, which is a purulent material in the pleural space that is very gunky and has to be, it doesn't allow for good air exchange on the good side, on the one lung that's left. And also, bronchopleural fissures can also happen because of that pneumonectomy where the lung was removed from the bronchus. I'm going to stop recording one here at the end of postoperative care for the pneumonectomy.